Hello, my name is Cassie Coleman-Hepler. I'm the clinical consultant for Pacific Northwest Helping Hands, and I'm here today to do a training with you on trauma-informed care. So the first thing I want to make sure is that you have a piece of paper or several sheets of paper and that you're taking notes throughout the training. There will be quiz questions given throughout the training, and once you have written out the answers, you're going to go ahead and turn those into HR, who are going to give you a copy of your certificate of completion. So I want to cover first what is the agenda for today. What is it exactly that this training is going to consist of? Just to give you a heads up, it should take anywhere between 45 minutes to an hour based on if you stop or start. So we're going to cover what is trauma and give you a working definition of what trauma is. We're also going to cover trauma-informed care and define what that means. That phrase is used often, trauma-informed care. I want you to have a really good working understanding of what it means to be trauma-informed. We're also going to cover some of the research on trauma that's been done in the last 20 years, especially those conducted in the ACE study by the Centers for Disease Control, as well as studies done in neuroplasticity and those studies being done out of Harvard in epigenetics. We're also going to cover how exactly you can help. What are the resilience skills that you need to learn in order to teach our youth how to improve their resiliency to combat the trauma that's happened to them. Now know that this training is specifically been catered to those of you who are working in residential treatment services for youth, as well as those who are working with unaccompanied minor refugees in our programs. Other people will get something out of the content of this training, but I just want to be upfront that the training itself has been catered to those two populations. Okay. So the first thing I want to give you is a working definition of trauma. Now, I made the little kind of icons at the top because I think it's a good way to kind of get it in your head, but I'm going to go ahead and read the trauma definition from below. So in this text, the term trauma refers to experiences that cause intense physical and psychological stress reactions. It can refer to a single event, multiple events, or a set of circumstances that is experienced by an individual as physically and emotionally harmful or threatening, and that has lasting adverse effects on the individual's physical, social, emotional, or spiritual well-being. So although many individuals report a single specific trauma event, others, especially those seeking mental health or substance abuse services, have been exposed to multiple or chronic trauma events. So again at the top, a traumatic event's trauma is a single event, a series of events, or a set of circumstances that causes physical or emotional harm in a person's well-being. And their well-being can be physical, spiritual, social, or emotional. So trauma can affect people of every race, ethnicity, age, sexual orientation, gender, psychosocial background, and geographic region. Really, trauma knows no limits nor boundaries. A traumatic experience can be a single event, a series of events, or a chronic condition. So, for example, childhood neglect or domestic violence, or even witnessing domestic violence. Traumas can affect individuals, families, groups, communities, specific cultures, and generations. For example, the grandchild of somebody who survived the Holocaust, or some of our youth that have come from cultures where their entire community has suffered genocide. So it generally overwhelms an individual or community's resources to cope, and it often ignites a fight, flight, or freeze reaction at the time of the event, or any subsequent stressors that remind them of that event. So it frequently produces a sense of fear, vulnerability, and helplessness. So for my first quiz question, I want to ask you, is trauma A, a single event, B, multiple events, C, a set of circumstances, or D, can be any of the above? I'm going to go ahead and repeat that. Is trauma a single event, multiple events, a set of circumstances, or can it be any of the above? So when I was reading that working definition, I talked about fight, flight, or freeze. So the way this works in our brain chemistry is that you're experiencing a stressor, and the stressor can be at the time of the experience, but also can be the remembrance of the experience, or even having a nightmare or a dream about the experience. So the interesting thing about trauma is that when you're experiencing kind of flashbacks or nightmares or memories of the trauma, your body actually remembers the same experience that it went through at the time of the trauma. It almost takes a scanning photograph of that moment. And the reaction can be to fight, which is why we see a lot of our youth who kind of act out with maladaptive behaviors and are wanting to fight in those circumstances. We also have other youth who have happy feet and need to run away or have an urge to run away in those circumstances, as well as some of our youth who freeze. They just completely shut down, no emotional reaction. Maybe they can go to their room. There's definitely a freeze response that's happening. So I just wanted to kind of point that out, that a stressor, while in the moment, or even the memory of a stressor or a trauma, can experience within the child's body a fight, flight, or freeze reaction. Which leads me to my next question. When a person becomes overwhelmed to the point of stress, the brain can react by F, or F. So repeat the question. When a person becomes overwhelmed to the point of stress, the brain can react by F, or F. So go ahead and fill in those blanks. All right. Now I want you to recognize that trauma-related symptoms and behaviors originate from adapting to traumatic experiences. Now these next few slides is going to be a lot of reading, a lot of me talking, but just kind of pay attention to the content. So behaviors are a person's best attempt to manage, cope, and rise above their experiences of trauma. So a trauma-informed perspective views trauma-related symptoms and behaviors as an individual's best and most resilient attempt to manage, cope with, and rise above their experience of trauma. Some individuals' means of adapting and coping have produced little difficulty. So the coping and adaptive strategies of others have worked in the past but are not working as well now. Some people have difficulties in one area of their life but have effectively negotiated and functioned in other areas. So for example, we have some kids who do absolutely fantastic in school, but they really struggle in home environments. Or vice versa, they really struggle in school but do fine in home environments. We just don't see those behaviors there. That's really common to see. So individuals who have survived trauma vary widely in how they experience and express their traumatic stress reactions. So traumatic stress reactions vary in severity. They're often measured by the level of impairment or distress that the client reports and are determined by the multiple factors that characterize the trauma itself. So it can be individual history characteristics, developmental factors, sociocultural attributes, and available resources. So the characteristics of trauma and the subsequent traumatic stress reactions can dramatically influence how an individuals respond to the environment, relationships, interventions, and treatment services. And those same characteristics can also shape the assumptions that clients or consumers make about their world. So their view of others, their sense of safety, their future, whether or not they have feelings of hopelessness or a fear of foreshortened future, and themselves, so whether or not they feel resilient or feel incompetent in regulating their emotions. So the breadth of these effects may be observable or subtle. So once you become aware of the significant traumatic experiences in the client's lives and begin to view their presentation as adaptive, your identification and classification of their presenting symptoms and behaviors can shift from a pathology mindset. So that means defining a client strictly from their diagnostic label, implying something is wrong with them. For example, quite a few of our youth have labels such as conduct disorder, oppositional defiant disorder, or attention deficit hyperactivity disorder. So that's pathology. To one of resilience, a mindset that views clients presenting difficulties, behaviors, and emotions as responses to surviving said trauma. So in essence, you'll come to view the traumatic stress reactions as normal reactions to abnormal situations. In embracing the belief that trauma-related reactions are adaptive, you can begin relationships with the clients from a hopeful, strengths-based stance that builds upon the belief that their responses to traumatic experiences reflect their own creativity, self-preservation, and determination. So the quiz question becomes, what is trauma-informed care? Is it A, a shifting from a pathology to resilience model? Is it B, defines a client by their diagnosis? Is it C, a mindset that views clients presenting difficulties, behaviors, and emotions as learned from responses to trauma? Is it D, none of the above? Or is it E, A, and C? Let me repeat the question. What is trauma-informed care? A, a shifting from pathology to resilience model. B, defines a client by their diagnosis. C, a mindset that views clients presenting difficulties, behaviors, and emotions as learned responses to trauma. Is it D, none of the above, or is it E, A, and C? So now I'm going to go over something called the keys to becoming trauma-informed care. It's a really handy way to kind of remember trauma-informed care, kind of like in 8 simple little phrases. So key 1 is that you need to recognize this may be trauma and their way of adapting. So when you see of it as a behavior or maladaptive behavior, it is probably trauma and their way of adapting to the trauma that they've experienced. Key 2 is you need to minimize the risk of re-traumatization and replicating prior trauma. Remember earlier when I talked about the fight, flight, or freeze response, and then our body takes almost a photograph of that traumatic kind of experience, that stressor, the body takes a photograph of that. Simply asking about the trauma can bring on that moment of stress and can bring back that photographic picture. So be aware of how you ask questions, what you're asking. Know that you're not the client's therapist, and even the idea of what people have about therapy is for the most part wrong when it comes to trauma. And let me give you a kind of concrete example. I do diagnostics with clients all the time. And when you're doing a diagnostic, there's one particular question that is asked, and I have to ask it, but the way I ask it, I feel, is very trauma-informed. So the question is, have you experienced any trauma? Now, the way this is normally asked as, can you tell me about any traumatic experiences you've been through? Now, for me, that's re-traumatizing, and I would never ask it in that way, even though that's a standard way of asking it on a diagnostic procedure. So what I do instead is I say, I'm going to ask a question, and it may be difficult, but all I'm looking for is a yes or no response. I don't want you to go into it today. We don't really have time to kind of unpack it today, but I'm just going to ask you about whether or not you've experienced any traumatic experiences in your life, and all I need is a yes or no answer. Do you see how that's a little bit more trauma-informed than, can you tell me about all the trauma you've been through, and how that would be almost impossible to have in a diagnostic session that's like asking for years worth of trauma in one answer. So key 3 is to create a safe environment. Now I know that sounds kind of silly, especially in our residential homes, because so many kids are having adverse maladaptive behaviors to trauma all the time. But I think for the most part, the programs are set up in ways where we've tried to kind of work around that. Clearing the floor, making sure that we're processing with each youth after a crisis or intervention happens. Having that one-on-one time with the youth too, in order to process when another youth has had an incident. All of those things are part of creating that safe environment. And really, one of the major ways that we create a safe environment is by being consistent. Key 4 is support control, choice, and autonomy by collaborating with the client. So each one of our youth gets a treatment plan. And in the treatment plan, it tells what some of the goals are for them to be working on. Now that should be done collaboratively with the youth. It should be talked about with the youth. The youth should be on board with that treatment plan. If they need to make changes or want to add to it, we should certainly listen to them regarding that. I always want to give them the choice in that matter. There are going to be certain goals that their social worker or whoever referred them to our community want them to meet, but we also need them to kind of feel like they have a little bit of power control over that. That's why we have weekly updates and monthly letters that are then given to the youth. It's because of this key 4 that we want to support controlled choice and autonomy. Key 5, you need to view trauma through a sociocultural lens. So this isn't just with our refugee programs, which seems kind of obvious, but also viewing trauma through a sociocultural lens of things that aren't as obvious, like did they grow up in a household of poverty? Where there might be some different kind of shifting morals and views about how life is supposed to be. So keeping that in mind, did they grow up in a rural community or an urban community? We get a lot of youth from all over the state, even outside of the state, so just being aware of kind of where they've grown up, the sociocultural context lens that they've been in. Key 6, use a strengths perspective. Now, when I was first in school, this phrase was used all the time, and I thought I understood it until I started working. And I remember the reaction I got. I was working in juvenile detention, and I was sitting in front of a kid who had actually murdered someone, and I said, "I see here from your records that you like to skateboard." So in my mind, I thought strengths perspective was about what they liked, and what I have learned over the years is that that's not what that means at all. What it means is, what are their values? What are their core beliefs? What do they have going from them? If somewhere on the report it says that Johnny is very kind and helpful and likes to help out his foster parents, we're going to kind of embrace that and nurture that and look at that from a strengths perspective. And we're going to make sure Johnny's given all kinds of opportunities to feel and believe that he's helpful and kind and the type of person who somebody wants to have around because he's so helpful. We're going to nurture that. Key 7, foster trauma-resistant skills. Now we'll talk a little bit about what these trauma-resistant skills are, because I like to think of them a little bit more like armor. So that way when another traumatic experience happens, you have that armor and it's available to you. You have those skills at hand. Key 8, develop strategies to address secondary trauma and promote self-care. So what is secondary trauma? Secondary trauma, my friends, is all about you. It's about you as staff members and making sure that you are taking care of yourself and that you are putting healthy boundaries up between you and the youth, so that way when you go home, you're not taking it home with you, that you are practicing self-care, that you are learning some of these trauma-resistant skills yourself to protect yourself from actually reacting to a youth's trauma. So that leads us to our next quiz question. Name just one key that I just went over to being trauma-informed. So again, the question, name one key to being trauma-informed. All right, now I want to talk about what are some of the responses to trauma that are common for a lot of our youth to go through. So this isn't an exhaustive list, but it is fairly interesting to me as a clinician, because this list of symptoms or responses to trauma are so similar to the symptoms that you would see for other pathological diagnostics. So for example, you would see a lot of these same responses to trauma when you're looking at a diagnosis like ADHD or a diagnosis like depression or anxiety. So a lot of times there's going to be kids that have probably been misdiagnosed. What we're actually seeing is trauma, but because of the way the diagnostic manual is set up, it makes it really difficult to diagnose trauma in youth. It actually is a lot easier to diagnose you with PTSD as an adult rather than as a child. So a lot of children end up getting other things because their presenting issue just looks just a little bit different. But we're going to go over what are some of the responses to trauma that are pretty common. Sleep issues. So sleep issues can be nightmares, bedwetting, bed soiling, so that's encopresis and enuresis. It can be things like sleepwalking or having difficulty falling asleep or waking up throughout the night. One thing that I do want you to kind of keep in mind is that young children, children under 12, probably should not be snoring. So night shift, if you ever see a kid or document one of our youth who is snoring in the night, please bring that to the attention of your program manager, because that's usually an indication of something else going on, like allergies or some type of sinus issue or something more severe medically. Physical complaints. So sometimes we have kids who have physical complaints, and that's their common experience or response to trauma. And it doesn't necessarily mean that their physical complaints aren't real. It just means that their pain threshold might be different than most people. When you're really young and you fall down when you're like a baby or a toddler, you have almost like an overreaction to pain. And that reaction to pain is usually, strangely enough, based on your caregiver's response to pain. But what if you had a caregiver who didn't give any response to anything other than maybe times when you were severely ill? So then you have people who, as they kind of grow older, they know that they're going to get physical affection or contact if they're ill, so maybe they might show more somatic complaints as they're older. That's super common to see. Another reaction is numbness or detachment. So this can be like blank stare, flat affect, just kind of glazed over, those kind of things. So numbness or detachment during stress is a really common reaction. Depression. So depression in all its forms, feeling as hopelessness, sadness, even suicidal thoughts or thoughts of self-harm is pretty common response to trauma. Heightened startle reactions, that's that jumping. I'll talk about this a little bit more later, but we almost think that all kids like surprises or everybody likes surprises. A child or a youth that's been through trauma does not. So I like to minimize the amount of kind of surprise things that we do. You really want to let them know ahead of time anything that's going to be happening because of the heightened startle reactions. Avoidant behaviors. So avoidant behaviors is avoiding anything that reminds them of the trauma or anything kind of trigger related. So let's say you got in a car accident. It would be a little bit difficult probably the next time for you to get in a car, even though, the statistics might be low that would happen again. It's just you kind of avoid situations that remind you of that trauma. Hyperarousal. Now it's interesting because I want to bring in hyperarousal and difficulty concentrating and kind of lump those together for a second, because hyperarousal and difficulty concentrating are two of the symptoms that you see with ADHD, and they're also very present in trauma. Emotional dysregulation. So emotional dysregulation is when, their emotion doesn't quite match their behavior, if that makes sense. So it can be something like they hurt themselves, but they start laughing, or, they're in a particularly having a great time, and then suddenly it can be a shift in moods or emotion. So their moods are just kind of dysregulated and all over the place. It is the main reason why I spend so much emphasis in a lot of your training on emotional vocabulary. Because as a clinician, what I have noted is that the greater increase you have in your ability to express your emotions and define your emotions and communicate that with another person, the less you have of the emotional dysregulation. So it can also cause cognitive changes regarding your beliefs about the future, self, and the world. You can have a kid who grew up really optimistic and hopeful and happy, and suddenly they're very withdrawn, closed in on themselves. They're living like a throwaway life. They're not really having a lot of beliefs in the future. They don't think anything great's going to happen. They have a real big shift cognitively about how they view the world. And then another kind of obvious, but definitely needs to be stated reaction to trauma is re-experiencing the trauma. So that can be either through nightmares, flashbacks, or having memories of the specific trauma. So now the quiz question becomes, I want you to name 3 of those common responses to trauma that a person can have. So let me repeat that. I want you to name 3 common responses to trauma that a person can have. So now I want to talk a little bit about the ACE study. So the ACE study was done through the Centers for Disease Control. And so I'm going to do a little bit of reading just because I feel like this slide really encapsulates the study really well, and then we'll go into a little bit more detail. So ACEs stand for Adverse Childhood Experiences that harm children's developing brains and lead to changing how they respond to stress and damaging their immune systems so profoundly that the effects show up decades later. ACEs causes much of our broken and chronic disease, most mental illnesses, and are at the root of most violence. ACEs comes from the Centers for Disease Control and Kaiser's Adverse Childhood Experiences study, a groundbreaking public health study that discovered that childhood trauma leads to adult onset of chronic diseases, depression and other mental illness, violence, and being victims of domestic violence and violence in general, as well as financial and social problems. So the ACE study has published about 70 research papers since 1998. Hundreds of additional research papers based on the ACE study have also been published. So the key to ACEs that they've measured are the physical, sexual, and verbal abuse that you've been through, the physical and emotional neglect, if you've had a family member who's depressed or diagnosed with another mental illness, whether or not you have a parent who was addicted to alcohol or another substance, or did you have a parent in prison, whether or not you've witnessed a mother being abused, and losing a parent to separation, divorce, or another reason. So subsequent ACE studies and other ACE surveys have expanded the types of ACEs to include things like racism, gender discrimination, witnessing a sibling being abused, witnessing violence outside of the home, witnessing a father being abused by a mother, being bullied by a peer or an adult, involvement with the foster care system, living in a war zone, so those 2 are almost kind of the key to a lot of our population that we have, living in an unsafe neighborhood, losing a family member, and deportation. So ACEs fall into 3 large categories. So you have adverse childhood experiences, adverse community experiences, or adverse climate experiences. For the purpose of what I'm going to go through today, we're going to refer to ACEs as adverse childhood experiences. So now I want you to actually see an ACE study. Now I need you to know, based back on that, I would never ask the traumatic question. I never ask these questions of a child, ever. What I do tend to do is that when we get a new referral that comes in, I look through their records and I try to gather as best as possible what I feel their ACE score might be. So these are some of the questions that make up the initial ACE study. You can fill this out or not. It's totally up to you. I'm not going to require you to it by any means, but I think you should know what kind of the ACE questions are as we go into some of the data behind what the results are. So prior to your 18th birthday, did a parent or other adult in the household often or very often swear at you, insult you, put you down, or humiliate you, or act in a way that made you afraid that you might be physically hurt? No, and if yes, enter 1. Did a parent or other adult in the household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? No, and if yes, enter 1. Did an adult or person at least 5 years older than you ever touch or fondle you, or have you touch their body in a sexual way, or attempt or actually have oral, anal, or vaginal intercourse with you? No, if yes, enter 1. Did you often or very often feel like no one in your family loved you or thought you were important or special, or your family didn't look out for each other, feel close to each other, or support each other? No, if yes, enter 1. Did you often or very often feel like you didn't have enough to eat, had to wear dirty clothes, had no one to protect you, or your parents were too drunk or too high to take care of you or take you to the doctor if you needed it? No, if yes, enter 1. Were your parents ever separated or divorced? No. If yes, enter 1. Was your mother or stepmother often or very often pushed, grabbed, slapped, or had something thrown at her, or sometimes often or very often kicked, beaten, hit with a fist, or hit with something hard, or ever repeatedly hit over at least a few minutes or threatened with a gun or a knife? No. If yes, enter 1. Did you live with anyone who was a problem drinker or alcoholic, or who used street drugs? No. If yes, enter 1. Was a household member depressed or mentally ill, or did a household member attempt suicide? No. If yes, enter 1. Did a household member go to prison? No. If yes, enter 1. So now you go ahead and add up your yes answers, and that will give you your ACE score. So the quiz question, what do the letters ACE stand for? So what do the letters ACE stand for in this context? Okay. So now we're going to talk about some of the outcome data that came out of those ACE studies. And this is not exhaustive. I just grabbed, like 8 slides that kind of told a real good, I felt, overview of the ACE study and kind of what the outcomes were of it. So out of the ACE study, the top left side, substance abuse was found in 27% of respondents. Parental separation or divorce was seen in 23%. Mental illness was seen in 17% of respondents. Having a battered mother, 13%, and criminal behavior, 6%. Psychological abuse was seen in 11%, physical abuse, 28%, and sexual abuse, 21%. Emotional neglect was seen in 15%, and physical neglect was seen in 10%. So on the top right, you can see childhood experiences definitely underlie chronic depression. And in this slide, red represents women and yellow men. And if you have an ACE score on the bottom of 4 or more, it almost kind of increases your risk of being diagnosed with depression 60%. Bottom left, childhood experiences versus adult alcoholism. 4 or more ACE score increases your score by over 16%. Bottom right, ACE score and the rates of antidepressant prescriptions. 5 or more, almost 100%. ACE score and the risk of perpetrating domestic violence for women higher than 5, it's over 10%. For men higher than 5, it's around the 13-14% range. Adverse childhood experiences versus smoking as an adult. 5 or more increases your percentage by, it looks like, about 17%. The ACE score and the prevalence of liver disease or hepatitis jaundice issues. ACE score of 4 or more, over 10%. Childhood experiencing underlying suicide attempts. ACE score of 4 or more, almost 20%. So I want you to name 2 areas that I just went over that ACEs can affect your physical health later on in life. So 2 areas that having a ACE score can affect your physical health later on in life. And remember, that was not an exhaustive list. There was actually a lot more than that. So now there's a second part to the ACE studies that have been kind of bantered around. And this one I always find almost like a little ray of sunshine or hope. And this whole kind of last half of the training is going to be expanding on this idea of what is that armor that we can give? How can we kind of help somebody who's been through trauma make it through the other side? Is there hope to the work that we do? Now, this resilience questionnaire, I think, is absolutely a brilliant way of looking at it, because you can have your ACE score and you can have, 4 or more, which increases your risk. But then at the same time, if you can also have a really high resiliency score, which I feel just kind of balances out that ACE score. So I'm going to go ahead and read you some of the resiliency questions that I just think are kind of brilliant. because in a lot of ways it helps you with what your job description is. So I believe that my mother loved me when I was little. I believe that my father loved me when I was little. So, and then the answers are going to be like definitely true, probably true, not true, probably not true, or definitely not true. So back to question number 3. When I was little, other people helped my mother and father take care of me, and they seemed to love me. Number 4, I've heard that when I was little, someone in my family enjoyed playing with me, and I enjoyed it too. When I was a child, there were relatives in my family who made me feel better if I was sad or worried. When I was a child, neighbors or my friends' parents seemed to like me. When I was a child, teachers, coaches, youth leaders, or ministers were there to help me. Someone in my family cared about how I was doing in school. My family, neighbors, and friends talked often about making our lives better. We have rules in our house, or had rules in our house, and we were expected to keep them. When I felt really bad, I could almost always find someone I trusted to talk to. As a youth, people noticed that I was capable and could get things done. I was independent and a go-getter, and I believed that life is what you make it. So the parts of this that really kind of resonate for me when I'm training staff in BRS or in Refugee is this idea that somebody cares about me. There's somebody who's always there that I can trust, who's there to listen to me. Somebody cares about my grades, that I have rules in my house and I was expected to follow them, that I was independent, because I feel like our programs really are catering to those resiliency skills and teaching those resiliency skills in youth. So I just wanted to bring that to your attention. So again, we're going to talk about how do you support someone who's experienced trauma, and I'm going to talk about, I really enjoyed this slide out of ECHO parenting programs. And they talk about predictability, space, perspective, recalibration, attribution, reciprocity, support, and choice. So predictability on here is that everyone loves surprises. Not. So I talked about this earlier. Trauma survivors often prefer predictability because that feels safer. So no to the surprise party, sorry, and keeping our schedule really predictable and safe and up on the board where they know what's going to happen next is really critical, and we can't emphasize that enough. Space, allowing time for the survivor to calm down, to take perspective. So trauma survivors often have difficulty regulating their emotions, and it takes them longer to calm down. I want to emphasize that we don't use the phrase calming down to our clients, though. We don't say, I need you to calm down, because as I often say, nobody in the history of calming down has ever calmed down when asked to calm down. You just go ahead and give them space. Recalibration. So you need to rid some language from your vocabulary, and some of that language can be harming in ways that we aren't even always aware of. So rid phrases like overreacting, you're oversensitive, or you're over anything from your vocabulary, and you'll find that this work will be a lot easier. Perspective. Be aware that when the past is introduced into the present, don't take responsibility for it. It's not yours. Go gently. Try to get some perspective on that. That what we're dealing with always is the trauma. So attribution, don't refer to the person's upbringing, problem, issues, behaviors. Call it for what it is, trauma. Reciprocity, give what you already need to receive. So listen, empathy, empowerment cannot be kind of emphasized enough. Support, be kind, loving, and patient, but emphatically set limits. So you have needs too. Boundaries, boundaries, boundaries. Choice. It can be a big trigger when a survivor is denied choice. So make sure that they are conferred and that you collaborate with them in any decisions that are made. So another way of looking at it, all of these are really good examples of how we can help. So what works to help the damage done? So I talked in the very beginning that, you know, the ACE study was definitely groundbreaking, but there's been so many other studies that's super exciting in this field, including Harvard University is studying something called epigenetics, and then some other researchers, especially Dan Siegel and a lot of other people are researching the ideas and concept around neuroplasticity. Okay, what does that mean? Research is being done in various institutions showing that the brain is in fact plastic. So plastic, it just means that it can adapt and change. Networks can be rewired, lost information can be learned again, and it gives hope. So when I was first learning how to be a social worker and a therapist, it was in the early 90s. And during that time, there was the general belief being held in the field that, you know, once you lost brain cells, they were gone forever. You know, like if you damaged part of your brain, you couldn't get that back. And what we're discovering with more and more research is that your brain can actually rewire itself, and it can adapt and it can change and it can learn new things. So you can teach an old dog new tricks. You can learn different ways, new ways of adapting to a traumatic event. Your brain can essentially rewire itself as long as you're kind of helping it along the way. So how does it happen? It happens through things like relationships, learning coping skills, reducing stress, and routine. So relationships, having strong and supporting relationships can make a huge difference. The key is that they need to be compassionate ones. Reducing stress, so it may seem simple, but figuring out what exactly is causing the flight, fight, or freeze response and reducing it. So what are their triggers, and can we reduce those? A really good example I give of that one is if we've had a kid who's, abusive parent locked them in their bedroom, having them take time in their bedroom to reset isn't going to be an effective strategy for that kiddo. A much better strategy would be doing something like a time in, where you go and you actually sit with them. You don't have to talk to them, you don't even have to process, but just being near them is a better alternative to a kid, where actually going and being alone in their room might be a trigger. Coping skills, so increasing the coping skill that the youth has and helping them make it more adaptive. So let's say, one of the coping skills that a kid has is reacting with anger. That's not necessarily a bad thing. It means that they kind of viewed whatever happened to them as wrong, which is good. I'd almost rather have a fighter than a kid that just kind of shuts down and freezes. So realizing that some of those coping skills can kind of be tweaked a little bit and nurtured, and you can help them along the way to make it a little bit more adaptive and helpful would be good. Routine, so having and keeping an established routine that they can trust, as well as reducing any unnecessary changes or transitions count as well. So we have some youth who, when they go on visitations with their family, we allow them a little bit of extra time when they return to come back into the program and get reacquainted with the program. Now, transition time can be in anything from going and reading a comic book, or having reading time, to taking a bath. Can really be really helpful for getting a kid back into the program. Anything that's just a little bit can ease those transitions is helpful. So this particular slide comes from the Harvard study, so it kind of takes all of those things that we've talked about the past few slides, narrows it down into reducing the sources of stress, strengthening their core life skills, and support responsive relationships. And for children, knowing that healthy development and educational achievement are important. For adults, the responsive caregiver and having economic stability. All of those things kind of lead to resilience and better ways of helping our youth get through. So now we're on, this is the final slide as far as questions go. So this is your last question. There are a couple more slides, but this is the last quiz question. Name 3 ways that you can support someone who has experienced trauma. So again, name 3 ways that you can support someone who has experienced trauma. Okay, so I like this slide just because it shows you what's not trauma-informed and how do we change it into a trauma-informed way of looking at it. Again, this one comes from Echo Parenting and Education. So if you're using phrases like power over, it's more like power with. You can't change to your brain is plastic. Judging to observing. People need fixing first to people need safety first. Operate from the dominant culture, so having cultural humility. People are out to get you. People can live up to the trust you give them. Having a right or wrong response to there's multiple viewpoints in life. From helping to learning. From you're crazy to it makes sense. From compliance, obedience to empowerment and collaboration. From need to know basis for info to transparency and predictability. To the presenting issue to the whole person and their history. To us versus them, and we're all in this together. From labels and pathology to behavior as communication. From fear-based to empathy-based. From I'm here to fix you to support and healing. From didactic to participatory. To people make bad choices to people who feel unsafe do unsafe things. From behavior viewed as the problem to behavior viewed as the solution. To what's wrong with you to what happened to you. From blame and shame to respect. The goal is to do things the right way to the goal is to connect. From prescriptive to choice. People are bad to people are doing the best that they can. Consider only research and evidence to consider all lived experiences. The client is the expert. So that's it. Thank you. Make sure you turn in your answers to HR. And I just want to end this whole training by thanking you for the amazing work that you're doing with our youth. I know it's not easy. Make sure that you're taking care of yourself. And if you have any questions about this training, please let me know, and I will see you all soon. Bye.